Welcome to our teaching module, Addiction in Primary Care. As this is a large topic to cover, we have broken down the title into two parts, and this is part one. In part one of this module, we will cover a short introduction to addiction, a brief pathophysiology, the diagnostic criteria of substance-related disorders, and how to approach, screen, and manage some cases. Now let's begin. The American Psychiatric Association, or APA, describes addiction as a complex condition, chronic relapsing brain disease that is manifested by compulsive substance use despite harmful consequences. So why is it complex? Because addiction involves functional changes to our brain circuit. We can divide addiction into two different types. One based off substances that includes alcohol to prescribe medications, and the other as behavioral addiction, for example, smartphone and internet addiction. So how do we explain how addiction occurs? Now let me introduce you to the brain reward system, or the mesocorticolimbic dopamine pathway. The reward system of the brain are a group of structures that are activated whenever we experience something rewarding, such as eating a delicious food, having sex, or using an addictive drug. When exposed to a stimulus that is rewarding, the brain responds by releasing an increased amount of dopamine, the main neurotransmitter associated with rewards and pleasure. Dopamine is mostly produced in an area of the brain called the ventral tegmental area, the VTA, located within the midbrain. It is then projected to an area called nucleus accumbens. The activation of the nucleus accumbens causes dopamine levels in this region to rise. This activation of the mesolimbic dopamine pathway tells us to repeat what just happened in order to feel the rewarding sensation. As a result, the individual will become more inclined to seek out that specific behavior or context in anticipation of the reward. Over time, through repeated exposures, this leads to learned behavior or habits. For instance, when you eat delicious food, you will feel the enjoyment and pleasure of eating it. You will remember where the food was purchased from, and you will be reminded of the joy of this food, which leads to seeking out the same place to enjoy that delicious food. Dopamine also travels to the frontal cortex, which brings about the conscious experience of this pleasure. Serotonin is an essential neurotransmitter associated with feelings of happiness. Due to the addictive substances like drugs affecting serotonin levels, this can get to a point where everyday activities, which an individual would have found pleasurable before, do not bring them happiness anymore, and could result in feeling very low in mood over the continued use of drugs. This can also be because these activities do not produce the same amount of dopamine that they are now accustomed to. All psychoactive drugs can activate the mesocorticolimbic dopamine system. These can trigger the release of more dopamine in the brain and increase the rate of cell firing. These drugs will typically bind to brain receptors in regions associated with rewards, for example, the VTA and the nucleus accumbens. They will force the brain to release a large amount of dopamine than would be released by healthy activities. Certain drugs, like methamphetamines, can also prevent the brain from reabsorbing dopamine, making the pleasurable experience last unnaturally longer. These overstimulation of the reward systems in the brain can eventually result in addiction. Drug addiction is a complex illness. The path to drug addiction begins with the act of taking drugs. Over time, a person's ability to choose not to take drugs is compromised. This, in large part, is a result of the effects of prolonged drug use on brain functioning and thus on behavior. Addiction, therefore, is characterized by compulsive drug craving, seeking, and use that persist even in the face of negative consequences. Based on types of addiction we mentioned earlier, let's focus on substance addiction. This is related to diagnosis of substance-related disorders. According to the DSM-5, substance-related disorders are recognized based on the use of 10 separate classes of drugs, as stated here. These disorders can be further divided into two different groups: substance use disorders and substance-induced disorders. But in this instance, we will focus on substance use disorders. The DSM-5, also the Bible of Psychiatric Diagnosis, defines substance use disorders as a cluster of cognitive, behavioral, and physiological symptoms, indicating that the individual continues using the substance despite significant problems. The diagnostic criteria can be fulfilled if the symptoms can be manifested by at least two of the following criteria within a period of 12 months. These are the 11 listed criteria by DSM-5 that covers impaired control over the substance use, evidence of social impairment, risky use of the substance, and the last two are the pharmacological criteria. As mentioned earlier, duration of symptoms must be up to 12 months, and severity is determined according to the amount of criteria fulfilled. 6 or more symptoms indicate severe, 4 to 5 symptoms for moderate disorder, while 3 symptoms and below indicate a mild substance use disorder. Psychoactive substances can be classified into three different groups. Depressants, where its main mechanism of action act on the brain by increasing activity of gamma-aminobutyric acid, a chemical that inhibits brain activity, which causes the drowsy and calming effects that make the medicine effective for anxiety and sleep disorders. Second, stimulants, which increase the activity of the central nervous system. These drugs are used by a very high percentage of the general population for various reasons, including performance enhancement, medical benefits, and recreational purposes. And finally, hallucinogens, which are a diverse group of drugs that cause an alteration in perception, thought, or mood. All three compounds have different chemical structures, mechanism of actions, and different adverse effects. So, what are the common substances you can find in our country? Based on findings of the National Health and Morbidity Survey of Malaysia published in 2019, 11.8% of Malaysians drink alcohol, and 1 in every 2 binge drink. The report also found 300,000 adults in Malaysia have used drugs at least once, with the highest being marijuana, followed by kratom, amphetamines, and opiates. They also found that most drug users begin between the age of 18 to 25 and started out with marijuana before trying other substances. Let's begin with these three common substances in Malaysia: opioids, amphetamines, and cannabis. All these substances come from different origins, with opium and cannabis initially plant-based, and amphetamines a synthetic man-made stimulant drug. It is also important to know the street names of these drugs when treating patients with addiction. Why? It is important to be able to speak the same language when trying to get a detailed history of their drug use, from potte for morphine, pil kuda or ice for amphetamines, and ganja or balut for cannabis. Each substance has different methods of ingestion that influences the duration and peak time of its effects to the drug users, from oral, nasal, inhalation, or intravenous method. These are the other three substances also highly listed from our National Health and Morbidity Survey of Malaysia in 2019: nicotine for tobacco, alcohol, and kratom, or locally known as ketom. This graph from National Institute of Drug Abuse shows inhalation and injection to be the two quickest ways to ingest a drug, while maintaining the highest concentration of drug in the brain, while oral ingestion takes a longer time to reach its peak and stays longer in the brain despite being in the lowest concentration. Now, which substances can be detected in urine? From this table, it is simplified that urine detection for each drug can last up to 2 to 3 days after last use, but may be detectable longer in patients with very heavy use or specific substances. Treatment options are similar in both ATS and cannabis use disorder, where the mainstay of treatment is psychological and medication is only for symptomatic relief or to treat comorbid psychiatric conditions. Opioids, on the other hand, is different due to the harm reduction method that includes medication-assisted therapy, specifically the methadone replacement program, which will be explained deeper in part 2. Here are the main types of opioids: natural opiates, which are alkaloids, nitrogen-containing base chemical compounds that occur in plants such as in the ricin of opium poppy; semi-synthetic opioids, which were created in labs from natural opiates; and fully synthetic opioids, which are completely man-made. That includes pethidine, methadone, and tramadol. Opioid use disorder is usually associated with other substance use disorders, especially those involving tobacco, alcohol, cannabis, stimulants, and benzodiazepines, which are commonly taken to reduce withdrawal of opioid symptoms or help with cravings. They are also at risk of developing mild to moderate depression. Intoxication of opioid is usually accompanied by pupillary constriction, some degree of drowsiness, and may also demonstrate inattention to the environment, even to the point of ignoring potential harmful events. Opioid withdrawal, on the other hand, is characterized by a pattern of signs and symptoms that are opposite to the acute agonist effects. Usually, subjective complaints of anxiety, restlessness, and an achy feeling often located in the back of the legs. For stimulant intoxication, it usually begins with a high feeling and includes euphoria with enhanced vigor, talkativeness, anxiety, hyperactivity, and impaired judgment that occasionally leads to social withdrawal. Severe intoxication can even lead to convulsions and cardiac arrhythmia and eventually death. Auditory hallucinations may be as prominent as paranoid ideation, and these symptoms must be distinguished from an independent psychotic disorder like schizophrenia. In stimulant withdrawals, acute withdrawal symptoms, or labeled a crash, are often seen after periods of repetitive highs. These periods are characterized by intense and unpleasant feelings of lassitude and depression, often leading to suicide ideation or behavior, and are the most serious problems seen during crashing. In a cannabis intoxication, symptoms can include injecting conjunctiva with dry mouth and tachycardia, while withdrawal of cannabis can induce anger or aggression, sleep difficulties, and even physical discomforts. For alcohol use disorder, in a state of intoxication, symptoms would include slurred speech, incoordination, and impairment in memory, while alcohol withdrawal, which happens after reduction or complete cessation of heavy and prolonged use of alcohol, will cause symptoms of autonomic hyperactivity. Last but definitely not least in our list of common substances is tobacco, where withdrawal symptoms can occur as early as within 24 hours of abrupt cessation or reduction, such as anxiety, difficulty concentrating, restlessness, and irritability that makes it hard for an active smoker to quit. So, how do we treat these disorders? There is no one-size-fits-all approach in managing addiction, but using the acronym SBIRT, SBIRT, does help improve the flow of management. S is for screening, which includes history taking, physical examination, and using specific screening tools. Then using BI or brief interventions approach before referring to centers that have trained personnel in managing specific substance use disorders to be able to give adequate treatment to patients. The most important part is history taking. History taking should involve a detailed history of current and previous drug use, social and medical history, as well as a mental health assessment to determine the current stage of change. As seen in this graphic, a line is drawn as a symbolic of a timeline for history according to the patient's age. When we mention detailed drug use history, you must always confirm the quantity, the frequency, and the duration of substance use pattern. For example, how old were you when you first used this drug? How long have you used this drug regularly? Which means frequency of use and amount used over the past 3 months. You must always have the last episode of drug use, the route of administration for each drug, questions on have you ever overdosed before, or have you ever experienced any withdrawal symptoms in the past? Now, medical history is very important. It may help us if patient is sick and in need of appropriate or urgent treatment. Ask the patient if they have any history of or currently have any seizures or epilepsy, diabetes, heart disease, liver disease, tuberculosis, any head injury, any physical or intellectual disability, allergies to medications, or any prescribed or over-the-counter medications that they are currently taking. A mental health assessment should include any previous family history of psychiatric disorders, any current symptoms of depression, anxiety, or psychosis, as these are common comorbids with the majority of patients with substance use disorders and would determine treatment options as well. Physical examinations, as stated, should include vital signs, height and weight, a full body review of any track or injection marks, bruises or tattoos, and any lingering smell of alcohol. A mental state assessment would review general appearance, mood, and effects, as well as cognitive function of the patient. There are many screening tools available for addiction, depending on the type of substance. For primary assessment, the widely accepted screening tool is using ASSIST, or short for Alcohol, Smoking, and Substance Involvement Screening Test. Otherwise, for alcohol, smoking, and specific addiction, you can always use these listed below. So what is ASSIST? So ASSIST is a basic screening tool developed for healthcare workers to use in primary care or welfare setting. It is also cross-culturally neutral, consisting of an 8-item questionnaire. It can take between 5 to 10 minutes to administer, and it covers all types of addiction. For our local use, we already have a validated Assist 3.1 that has been translated to Bahasa Malaysia, as you can see below. So this table shows Assist risk score calculated after initial screening. Based on the risk score, we can administer the necessary intervention, which includes brief intervention and a take-home booklet and information. For high-risk cases, the level and amount of intervention is higher, including the need to refer for specialist assessment and treatment. So what is brief intervention? Brief intervention is recommended short advisable intervention to administer in moderate to high-risk patients. As you can see, the first 5 steps should be given in a 5-minute session, while to complete the 10 steps may take up to 30 minutes. This can be done on the first visit after screening of Assist, and before giving the patient an appointment to monitor the progress, or a referral if indicated. During screening, it is also important to determine where the patient's position is based on stages of change, as this will also influence the treatment modality and outcome in the long run. Eureka is an original instrument for assessing the trans-theoretical stage of change using a 24-item scale regarding alcohol or drug use and their readiness to change. For example, if a patient is in pre-contemplation stage, there is unlikely any change behavior, but a brief intervention as listed would suffice. Unlike any other medical disease, we do not simply separate treatment into pharmacological and non-pharmacological treatment. In addressing addiction, we recognize that it's not just a simple matter of substances alone, but a complex interplay of biological, psychological, and social factors. Thus, embracing the biopsychosocial approach allows us to approach addiction treatment with a comprehensive understanding of its multifaceted nature, ensuring a more holistic and effective path to recovery. Now, this flowchart simplifies the earlier point if we separate treatment into pharmaco and non-pharmacotherapy. So medication is only given in cases of detoxification, to treat medical or psychiatric comorbidities like diabetes or schizophrenia, starting maintenance therapy in opioid use disorders, or for relapse prevention. In the journey toward addiction recovery, it's vital to recognize that healing extends beyond medication alone, and the mainstay of treatment is non-pharmacological. Non-pharmacological treatments for addiction focus on therapeutic and behavioral approaches to help individuals recover from substance use disorders without relying primarily on medication, such as brief intervention using frames approach, behavioral therapy like CBT to help individuals identify and change destructive thought patterns and behaviors associated with addiction. Health education, providing individuals with information about addiction, its effects, and coping strategies can be a valuable component of treatment. Motivational interview, which is to empower patients in finding their motivations and to set goals for recovery. Family therapy, involving family members in therapy can help address family dynamics and support an individual's recovery. Support groups like Alcoholics Anonymous and AADK provide a safe space for individuals to share their experiences and receive peer support. And finally, relapse prevention, which is an important component for teaching individuals to recognize and cope with triggers and cravings that can help prevent any relapse. Now, all these treatments are highly effective and are often used in combination with other forms of support. Non-pharmacological treatments are an essential component of addiction recovery and can be tailored to an individual's specific needs and preferences. So what is the FRAMES model? It is an acronym that represents a brief intervention developed to guide healthcare professionals in delivering effective short interventions to individuals struggling with substance use disorders, where the treatment goal is to decrease drug-seeking and drug-taking behavior. Each letter in the FRAMES model stands for a key element of the intervention. F, for feedback to the individual to raise awareness of the risks and negative consequences associated with their substance use. R, for responsibility, by helping them understand that they have the power to make choices and take control of their behavior. A, for advice. We should offer clear and specific advice on how to reduce or quit substance use. It should also be practical and tailored to the individual situation. M for menu of options. This stage involves presenting the individual with a range of treatment options from counseling, support groups, or other resources that are available at your center. E for empathy, which involves demonstrating understanding, non-judgmental, and support for the individual. It's important to create a non-confrontational and supportive atmosphere to encourage the person to open up, consider change. Finally, S for self-efficacy. In this stage, we help the individual build confidence in the capacity to make positive changes to overcome their addiction. The model is rooted in motivational interviewing principles and aims to motivate individuals to consider change, whether it's reducing their substance use or seeking further treatment. By addressing these key elements, we can facilitate conversations that promote self-awareness, responsibility, and a willingness to take steps towards recovery. In substance use disorder, medical treatment is indicated only as needed to treat accompanying symptoms or the comorbids. Paracetamol or NSAIDs in detoxification process for muscle aches and fever, antipsychotics to treat any underlying psychosis, and antidepressants for depression. However, only physicians and specialists trained in managing substance use disorders should prescribe such medications. If the condition is beyond your specialty, cases should be referred to the addiction clinic specialist or psychiatric doctors for treatment. After all that explanation, can you manage a patient you suspect of having addiction? Let's go to case number 1. A 28-year-old man came to clinic requesting for methadone. Claims he was encouraged by a colleague who is taking methadone in your clinic. A patient admits to history of smoking, taking potte, and marijuana. He was also told taking methadone would reduce his drug cravings, although he admitted to taking potte just last night. What other history would you need? That's right, a more detailed drug use history, medical history, as well as social history. Following what we have learned, you should proceed with the cyst and eureka for stages of change. So on his assist score, opioid score came up to 16. Nicotine score was 12. His Eureka assessment shows patient is in preparation stage, as he is intent on taking action, coming to see you, seeking methadone with the purpose to reduce his drug cravings. Now looking at his current stage, what would be the best management? Now look back at his assist score. 16 shows moderate risk, which means a non-pharmacological treatment where brief intervention with health education using motivational interview would suffice. Now let's go to case number 2. A 60-year-old male came to clinic with complaint of lethargy, nausea, and body ache for the past 2 days. He admits to being a heroin user for over 40 years, still using, and last took heroin about 2 days ago via Chase. On further history, he usually takes up to 50 grams 4 times a week, but 2 days ago he only took 25 grams, and he denies any past medical or psychological history. So how do you proceed? What do you do next? So you should proceed with assist screening, physical examination, and a urine for drug test. So your information shows assist score of opioid 33, nicotine of 12. Physical examination, alert pink pupils mydriasis, but no signs of intoxication. Otherwise, all else are unremarkable. Vital signs, BP 145/90, pulse rate of 87, and urine for drug shows positive opioid. What is the diagnosis and how do you proceed? So his diagnosis is opioid use disorder in withdrawal state. Why? His withdrawal symptoms are lethargy, body ache, pupil dilatation, and there is a sudden reduction of dosage of heroin used, which shows you can proceed with COWS or Clinical Opioid Withdrawal Scale. His assist also shows a high score of 33, meaning high risk. Brief intervention should be given, and patients should be referred to a specialist for assessment and addiction clinic. So this shows the type of intervention according to the level of risk, based on interpretation of assist score from low, moderate to high. This is the COW scale or Clinical Opiate Withdrawal Scale to assess the severity of withdrawal in opiate cases. In substance use disorder, after starting treatment, it is also important to review any risk of relapse. Thus, relapse prevention is actually part and parcel of management in addiction, regardless of the substance. By definition, relapse prevention is a tertiary intervention strategy for reducing the likelihood and severity of relapse following cessation or reduction of problematic behavior. One of the immediate determinants is a high risk situation, such as interpersonal conflicts like an argument with family, marriage problems, or work related issues that can cause stress and impact risk of relapse. Thus, CBT, a cognitive behavior therapy involving coping skills, avoiding pressured situations, skills to keep a healthy mind and focused, as well as having a good social support, is important as part of relapse prevention. We are finally at the end of part one. Here are some points I hope you have taken note of. Most important, that addiction is very much a chronic relapsing disorder and requires detailed history taking and proper screening tools to identify. It also requires a multidisciplinary approach and proper training. Thank you for your undivided attention, and I hope to see you in part two. Thank you for listening, and join me again for part two.